Good evening. We're now going to start. I want to start by thanking everyone who has joined us today. Thank you so much for creating time to come join this webinar that we're going to have today. I want to appreciate the KSA webinar organizing team for organizing this today's webinar. I also want to thank all the participants, both local and non-local, for coming in today. Just a guideline, we can use the chat for questions, which we will do a Q&A after the speaker has finished. So I'm Dr. Mbadi Ruth. I'm an anesthesiologist. I currently lecture at Jomo Kenyatta University of Agriculture and Technology, School of Medicine, Department of Anesthesia. Today, we are going to be talking about a physiologic approach to perioperative hemodynamic monitoring. And our speaker today is Dr. Idris Chikophe, who is an anesthesiologist at Kenyatta National Hospital. Thank you so much, Dr. You're welcome.
So can you hear me, Dr. Ruth?
Yes, I can hear you.
So thank you very much for that kind introduction. I'm gonna stop my video just to allow enough bandwidth for the presentation, and I'm going to share my screen. Can you see my screen?
Yes, we can see your screen.
So thank you very much for this opportunity to speak here today. It's a big platform. And today I'm going to talk about the perioperative hemodynamic monitoring. And a few things I'd like to speak before I speak. This session is going to be based on the tools that we have on a day-to-day basis. We are not going to talk about tools that are foreign to our setting. And also, this talk is about patients who are relatively sicker compared to the others. And therefore, they may need a little more intense monitoring. So these are the patients with the disease severity that is higher compared to other groups. And therefore, they need quite a bit of monitoring. So the agenda for today, of course, will be introduction, and then we look at macrocirculation. We look at a bit of electrophysiology, and we look at microcirculation. So what is monitoring? Monitoring has been described as the continuous observation of physiologic variables with the intention to reveal changes in organ function. And once you reveal these changes, then you may be prompted to intervene appropriately. And after intervention, you may want to reassess the response to your intervention. So it therefore tells you that the kind of monitors that we need to have must be those ones that are quick in picking those changes. So they must be real time, and they must pick the required signal, what we call the high signal to noise ratio. And of course, you want those monitors that are not so invasive, so that it doesn't matter who is practicing or who is giving the anesthesia. Anybody who is giving anesthesia may be able to use these monitors. And it's been shown that when you acquire new monitors, it does not necessarily translate to improvement in organ function. What has been shown to improve your organ function is actually the clinician being able to see this data, appropriately interpret it, and make an appropriate decision that is timely. That has been shown to improve organ function. So when you look at the cardiovascular system, basically, I'd like to go back into evolution I think we started as unicellular organisms, and our processes could just be met by simple diffusion. So oxygen will just come into our bodies or into the unicellular organism after internal respiration and production of carbon dioxide. That carbon dioxide will actually move out down the concentration gradient. But we became multicellular. We had cell specialization, and we had tissues that became also specialized to serve specific functions. And so we were not able to rely on simple diffusion. And that's why we developed an elaborate circulatory system. But it may also be very difficult to just talk about the circulatory system without mentioning the lungs. Okay, so like I was saying, we started as unicellular organisms, and we used to rely on simple diffusion to get the oxygen into these unicellular organisms. And after internal respiration and production of CO2 as an end product, that CO2 would simply diffuse outside the body, again, with the same process. But then at some point, we became multicellular, of course, with cell specialization, forming specific tissues that would serve, specific functions. And that's why we developed what we call the cardiovascular system. And I said it may be very difficult to mention the cardiovascular system without talking about the respiratory system, because the two systems are juxtaposed both anatomically and even functionally. And therefore, it means that the two systems have to work together, to sort of bring the external environment closer to our cells. So the circulatory system basically is a series of pipes and a pump, and we have the blood that comes from the rest of the body into the heart, into the right atrium, and into the right ventricle. And this blood is normally depicted as blue in color because it is poorly oxygenated. And then from the right heart, of course, it goes to your pulmonary circulation where it picks up your oxygen. And then after pulmonary transit time, it will move back to the left heart and eventually to your systemic circulation, where you shed some of this blood in the tissues that need it. So basically, the two, organ systems actually work very closely. So what is the goal of the circulatory system? The goal of the circulatory system is actually systemic oxygen delivery. So systemic oxygen delivery is a function of your hemoglobin combining power, what is called the Hofner's constant, and your saturation. So a great majority of systemic oxygen delivery is actually subserved by your hemoglobin, and a very small proportion is actually taken care of by, the oxygen that goes into solution. So basically, this is the equation that talks about systemic oxygen delivery. So you need to have your cardiac output with you for you to sort of maximally optimize your systemic oxygen delivery. The other reason, of course, is to maintain your cardiac output. You need volume support. If there wasn't volume in our veins, then I think we would all collapse. So that at the end of the day, we have stroke volume, which is basically the ideal thing to monitor if it was possible. Like I said, the kind of patients we're going to talk about are those high-risk surgical patients. These are, the high-grade American Society of Anaesthesiology, physiologic status, So we're looking at patients who've had cardiopulmonary illnesses, patients with the advanced vascular disease, like the aorta, elderly patients, of course, more than 70 years, who are frail and fragile, and the surgery involving major cavities like the chest and the abdomen, and sometimes the brain, the cranium. We are also looking at patients who have abdominal catastrophes like hemodynamic instability resulting from peritonitis, perforated viscous, pancreatitis, because these are associated with major fluid shifts. Patients who are receiving massive blood transfusion, patients with septicemia. Hopefully the source of this sepsis has been identified, And patients who have a hypoxemia requiring mechanical ventilation, of course, requiring very high FiO2s, and giving you, a PF ratio, that is really deranged. And of course, patients who are having acute renal failure. These are patients that need intense monitoring. So how do we monitor these patients? Of course, you could use clinical, variables like the heart rates. So heart rate variability, of course, is very, very important. When you lose your blood volume, you expect the heart rate to go up. Of course, when your blood volume is replenished, you expect the heart rate to normalize. However, what affects this heart rate variability? Of course, it's affected by physical fitness. A very fit athletic person normally maybe having a resting heart rate of 40. And so if they increase that heart rate to 60 beats per minute during a physiologic perturbation, that may be extreme tachycardia. So you have to understand who you're working with or who you're dealing with. And, these are patients who are also adapted to maybe increasing their stroke volume during physiologic stresses. So you may not really see a big change in your heart rate. So you have to be very, very careful. These are the patients who may actually lie to you that everything is fine. And by the time they're manifesting this increase in heart rate, it may be already too late. Of course, patients already on beta blockers, patients who have dysautonomia from chronic metabolic problems, they may not change as you expect normal humans to change. We always administer central sympathelytics like the dexmedetomidine. This will affect your heart rate variability. And of course, the epidural, you have this basal gyrus reflex whereby you have vasodilatation. So there's venous pooling of your blood. Your right atrial pressure sort of goes down. And this is a reflex that gives you a vagus tone. So you get, vagal mediated bradycardia. And this goes through the nucleus, the NTS nucleus, can I remember the name? But yes, there's a nucleus structure solitarius in the brain that mediates this reflex. So most of the time we think that when you get a bradycardia during spinal hypertension, we think that the spinal block is really high, but it's actually due to the venous pooling, because when you test our spinal anesthesia level, it's always well, placed. It's mostly in the lower lumbar or maybe upper thoracic, lower thoracic. It never really reaches your cardio accelerator now. That is your T1 to T4. So most of the reasons why we get bradycardia is actually due to the basal gyrus high spinal blockade. So heart rate is very, very important. Like we said, when you multiply the heart rate by your stroke volume, you get the cardiac output. But when you look at the mechanical cycle of your, the mechanical aspect of your cardiac output, the cardiac output is basically divided into, the cycle is divided into diastolic and systolic phases. So during maybe resting heart rates, when the heart is beating at 70 per minute, a shorter time is spent in systole, maybe around 0.24 seconds. And the longer time is spent in diastole, maybe 0.56 seconds. So if you're doing 70 beats per minute, and then you increase your heart rate to 140 beats per minute, it's been shown that there's a linear decline in your systolic time. But when you look at your diastolic time, it actually reduces exponentially. So when you double your heart rate, basically it compromises your diastolic time. Your diastolic time is very important because the heart is perfused in diastole, and the heart is also a pump, so it is denied enough time to fill. So basically, tachycardia will reduce both your cardiac filling and even perfusion. So tachycardia, I think, should be treated with the same urgency as a bradycardia. And of course, as anesthesiologists, we take heart rate variability seriously. The other thing that you may want to look at is your blood pressure. This is the pressure that is exerted on the vessel walls as a result of your ventricle contracting and ejecting blood. So blood pressure has various components. You have your systolic blood pressure. This is the maximal pressure ever attained. And it is the same both in your ventricle, left ventricle, and in the aorta. We want to take this one into consideration because in the perioperative period, systolic blood pressure may be responsible for bleeding. Bleeding can either be reactionary or, it can be due to, slipped ligature. It can also be microvascular, and you cannot maybe do much about it in terms of surgical technique. And even in trauma, those patients who are allowed to have what you call permissive hypotension, you're basically controlling your systolic blood pressure to a level that is normally lower than what is expected so that you minimize, bleeding. So for example, if a patient has had a clot, that clot is causing tamponade. And when you aggressively resuscitate the patient, the blood pressure goes up. You actually get bleeding. When you get vascular surgery, we still do vascular anastomosis. So if you increase your systolic blood pressure to very high values, you may actually get distortion or disruption of your stitches, and you may get postoperative bleeding. The diastolic blood pressure is the one that is responsible for organ perfusion, organ protection. The heart, of course, left heart is perfused in diastole. The right heart is perfused maybe throughout your cardiac cycle. But you've seen patients who have low diastolic blood pressure tend to have other complications. You have reduced circulation to major vascular beds like the splanchnic circulation. For those of us who work in the neonatal intensive care units, we see that patients who are born with the PDAs, they have very low diastolic blood pressures. And if they ever get sepsis in this situation, there is a very high risk of them getting necrotizing enterocolitis or even, acute kidney dysfunction, because, the diastolic time is very, very important in maintaining perfusion. Because when you look at the formula of your mean arterial pressure, the diastolic pressure actually contributes more. What is our mean arterial pressure? This is the time-weighted average in your blood pressure across your cardiac cycle. And it's thought to be the main determinant of perfusion out of all these three variables. And therefore, hypertension could be defined as a mean arterial pressure of less than 60 millimeters of mercury, or when you have a drop by 20% from your baseline. And, there's a concept called autoregulation, which is basically the maintenance of, relatively constant blood flow with changing mean arterial pressure. So the blue curve basically shows you normal, autoregulatory curve. And between maybe 50 to 150 thereabouts, you have maintenance of relatively constant blood flow to your vital organs. But look at a patient who is hypertensive, they're already used to higher pressures. So basically their, autoregulatory curve is actually shifted to the right. So it means they may need higher mean arterial pressure compared to patients who are not hypertensive. So it's very, very important to know which patient you're dealing with so that your targets of blood pressure are sort of tailor-made to the kind of patient that you're looking at. But it's not just enough to look at the numbers. Sometimes, like now, when you're managing these patients, we put the invasive monitoring, which is the arterial blood pressure monitor. So once transduced, it gives you a waveform. And this waveform basically is a mirror of your cardiac cycle, and of course, with the various blood pressure points plotted on it. So the lowest pressure is your diastolic blood pressure, which rises during systole to your systolic blood pressure. And of course, once you reach the peak of your blood pressure in the major vessels, of course, as blood flows to the rest of the body, the pressure starts to drop. And it drops, fast to just a point where now you start your diastole. And at this point is when your aortic valve closes. So what happens at this point? Because the blood pressure is reducing, it means the forward flow may actually reduce. And in fact, at the beginning of diastole, you may actually get negative flow, or flow that is going back to the vessel, to the heart. So for example, if somebody has maybe an aortic regurgitation, this flow may even be exaggerated. But in normal physiology, that backward flow is actually sort of reversed by the elastic recoil of the aorta, the Vien-Kessel effect. So basically, the dicrotic notch tells you that the aorta is still available for you to sort of propel the blood forward. All right. But now these blood pressure waves are actually dependent on the site where you put them. Okay. So in the aorta, being an elastic artery, you sort of find curves that are not really pointed. But as you move towards the dorsalis pedis, the curves are really accentuated. And as you move from the aorta to the dorsalis pedis, your blood pressure actually increases. And it increases by around 0.77 millimeters of mercury for every 1 centimeter below the heart. But when you look at this, your mean arterial pressure tends to remain constant. However, your systolic blood pressure tends to be overestimated as you move away from the aorta, and your diastolic blood pressure tends to be underestimated as you move away from your aorta, which is your masculine artery. But what about disease states? You know, so this is the normal curve, but whenever you have contractile dysfunction or systolic dysfunction, you see there's a reduced rise in your stroke, you know. Or when you have a stenotic valvular lesion, like in aortic stenosis, I think the rise of that, you know, stroke is sort of more gradual rather than being vertical. When you have a regurgitant valvular lesion, the rise tends to be very vertical, which is characteristic of hyperdynamic, you know, circulation. And sort of something in like in aortic regurgitation, you get the bifid wave. When you have sepsis with reduced systemic vascular resistance, you see your dicrotic notch is near the floor, and when you have intense vasoconstriction, your dicrotic notch is near the roof. So very, very important. And sometimes you get patients who have somebody with connective tissue issues, like, you know, is it scleroderma or dermatosclerosis? I'm not sure of the term. You actually find these patients don't have a dicrotic notch because the blood vessels are very, very, you know, stiff, and you just see inverted, you know, pyramids. So again, we may look at blood pressure as a static variable. You can also look at it as a dynamic variable. So a dynamic variable is based on what you call the cardiopulmonary interactions. Of course, you know, this is basically, you know, comes from the premise that the heart and the lung are very closely juxtaposed, like I said, anatomically and even functionally. So during positive pressure ventilation, you increase your intrathoracic pressure, and this pinches your inferior vena cava, and so your venous return tends to reduce. And during, you know, exhalation, when you release the pressure, your intrathoracic pressure sort of goes down, and your venous return improves. So you have your cyclic variation, you know, in inferior vena cava, pulmonary artery, and even aortic blood flow with your respiratory cycle. And so basically, this can also be mirrored on your pulse pressure wave. So your pulse pressure tends to change with your mechanical ventilatory cycles. So we say during inspiration, your intrathoracic pressure comes down, or during inspiration, your intrathoracic pressure goes up, you have your reduced venous return, reduced pulmonary blood flow, and after pulmonary transit time, you get a reduced stroke volume, and the process reverses during expiration. And your pulse pressure can actually be estimated, you know, by the difference between your peak and minimum pulse pressure divided by the average of the two values. And if the variation is too much, the patient may not be preload responsive. If the variation is above 13, this patient may benefit from fluid therapy. And between 10 and 13%, that is a gray zone. It could also be interpreted as the sweet spot because this is where you want your heart to be. Every human being in the physiologic state is a little fluid responsive. So what happens is that when you get a patient with features of hemodynamic instability and the patient is sedated, paralyzed, ventilated with a tidal volume of 8, not 6, and they're in sinus rhythm, you know, preferably with a closed chest, and then you measure your pulse pressure variation, If the patient is hypotensive and the pulse pressure variation is less than 10, you may want to use a cardiotonic drug like dobutamine or a similar inotrope. If it is between 10 and 13, you want to check, repeat after 15 to 10 minutes, 5 to 10 minutes. And of course, when it's more than 13, this patient may be hypovolemic and may benefit from a fluid bolus. However, it's been shown that the presence of a pulse pressure variation of more than 13 may not necessarily mean a volume problem. It could also be redistribution. So you may want to maybe start a pressor, and this pressor will actually increase your venous tone. And when you increase your venous tone, basically that augments your venous return. So it's like, in a way, giving an endogenous, fluid bolus. So basically, patients who deserve to be on vasopressors, they should get it as early as possible. Our reflex is always to give fluid, but some patients may actually, not benefit much from the fluid. What about the central venous pressure? Of course, there's a lot of debate as to whether a central venous pressure is an important parameter to have in the intensive care unit. But a lot of our patients, especially the sick ones, get central venous pressure, central venous catheter. So once you have a central venous catheter, it means this parameter could easily be accessible. There's a lot of literature that says, central venous pressure is actually losing its utility in predicting fluid responsiveness or even, assessing volume status. So basically, what is central venous pressure? Central venous pressure is basically pressure in the maybe lower 1/3 of your superior vena cava and maybe in your right atrium. So what does that mean? It just means that it is pressure. So why would you use pressure to try and estimate, volume? Because the two of them are different. You can't use pressure to estimate volume unless you calculate the relationship between pressure and volume, which is complex, but we'll see. So basically, your central venous pressure could easily be described as the point of equilibrium between your cardiac output and your venous return. Because we said the heart only pumps out what it receives. So if it receives a small amount of venous return, it can only pump as much. So you can see here that the venous return is reduced. So this is your venous return curve. This is called the Gates-1 curve. And your cardiac output curve is called the Frank-Starling curve. So at the point where the two of them meet is basically the point where your venous return is equal to your cardiac output. So for there to be venous return, of course, there has to be a pressure difference because blood is fluid and fluid moves from a region of a higher hydrostatic pressure to a region of a lower hydrostatic pressure. So it therefore means that without a pressure difference, you will not get venous return. So maybe you can assume that this is your right atrial pressure here towards 0, and your venous pressure, or what you call the mean systemic filling pressure, is maybe at point A. So you can see the difference between the two is very small, and therefore it means your venous return is very small, and the cardiac outputs achieved at this point is equal to your venous return at this point. So this is a low cardiac output state. But as you increase your difference between the right atrial pressure and your venous pressure, or the mean systemic filling pressure, in some situation, you may augment your venous return and your cardiac output may actually improve to this point. And if you increase it further, again, you may get to this sweet spot. If you keep on increasing your venous pressure, you may eventually end up on the flat portion of the curve. So every time you try to augment your venous pressure by giving more fluid, you can say you're going into a state of wasted preload, for example. So let's look at the pressure, how pressure moves from your arterial side all the way back into your right atrium. So in the arteries, the mean arterial pressure, of course, is around maybe 80 to 100, and it drops as you move away from the heart to the systemic circulation and back to the right side of the heart. Of course, the biggest drop is at the level of the capillary because this is where you have the greatest surface area. But there's a point at which now your pressure falls further, and it falls further below your main systemic filling pressure, such that the right atrial pressure is at a level below your main systemic filling pressure. So basically, what is this mean systemic filling pressure? This is the average pressure across all the vascular beds and the heart when there is minimum flow. So at zero flow, for example, like when a patient is having fibrillation or the heart is come to a standstill immediately after maybe cardiac arrest, when you measure the pressure in the right ventricle, left ventricle, right atrium, left atrium, aorta, inferior vena cava, and maybe the veins, that pressure is basically equal, is the same across all those anatomic locations that I've said, and it is called the mean systemic filling pressure, right? But this mean systemic filling pressure may be theoretical in a patient who is alive, and it is thought to be always higher than your right atrial pressure, and that difference is the one that governs your venous return. So when the gap is bigger, it may translate to a bigger venous return. When the gap is narrowed, it may translate to reduce venous return. So according to the Hagen-Posse equation, is that flow is directly proportional to the pressure difference. And when I'm looking at the venous return, I'm looking at the difference between your main systemic filling pressure and your right atrial pressure or your CVP. And of course, it also depends on the caliber of your vessels. It may be also affected in a negative direction by your viscosity and the length of the pipe through which this blood is flowing. But this equation has actually been adopted by Guyton himself, and he adopted with this important point in mind that the venous reservoir is distensible. So if you're to fill the venous reservoir without a pressure rise, the amount of blood that is needed to fill this reservoir is called the unstressed volume, because it does not lead to an increase in pressure. But any additional fluid that is given above the unstressed volume will lead to an increase in pressure. And the minimum pressure in a patient who is without cardiac disease or a patient who has normal vascular compliance is around 20 mLs. And probably this is the origin of your 20 ml per kilo bolus. So if a patient is maybe purely in hypovolemic state and they don't have cardiac disease or they don't have a problem with their vascular compliance, 20 mLs per kilo is the right thing to give. So we say this rise in pressure is actually dependent on your vascular compliance. And therefore, venous return may be obtained by getting the pressure difference divided by the resistance, because pressure, flow is basically you divide your pressure difference by your resistance. So it's very, very important, because why are we looking at all this? We're looking at all this because we want to interpret the CVP as a dynamic variable, not as a static variable, because long time ago, our superiors would ask us how much the CVP is, and then you say the CVP is 3, then they will tell us to give more fluid. But right now, we want to see how this CVP changes when you give a fluid challenge. So basically, what is a fluid challenge? A fluid challenge is a predetermined amount of fluid that you give to a patient, and you're hoping that this patient is connected to a monitor that will rapidly pick the changes in the physiologic variable that you're looking at. So basically, you give a predetermined fluid of a short period, preferably less than 15 minutes, and you look at the rise in your pressure. So if the patient has a pressure rise that is less than 3 centimeters of water, this amount of volume that you're giving is probably the unstressed volume. The patient is still very depleted volume-wise, such that you don't see a measurable change in your venous pressure. But when you give an additional bolus and the pressure rises by between 3 and 5 centimeters of water, the patient may just be where you want them, the sweet spot or the spot of euvolemia. But then if you give them a fluid bolus and the pressure changes by 5 centimeters of water, that patient has reduced cardiac and vascular compliance such that your intracardiac filling pressures will go up. So sometimes an increase in central venous pressure may mean that there's reduced capability to augment your venous return, because the difference in pressure between your main systemic filling pressure and your central venous pressure or rate atrial pressure is minimized. And again, it's been shown that when your intracardiac pressures are really high, that pressure may be transmitted all the way back to the venular end of your microcirculation. So there's going to be reduced reabsorption of the fluid that has already been ultra filtered, for example. So a high CVP may actually mean increased tissue extravasation. Okay, so sometimes, a high CVP may not necessarily be due to too much fluid. It could be also be due to cardiac problems. And yes, there's a case of a bleeding femur and a tension pneumothorax. You will get a normal or a high CVP in the presence of a hypovolemia. And of course, there's more information that you can get from CVP. CVP is not just numbers. You can also look at the wave. This is one of the most difficult waves to understand, but I remember that the A was due to atrial contraction. And in patients who have, atrial fibrillation, they lose their A. And so if they're dependent on the atrial kick, they'll have reduced cardiac filling. What about electrophysiology? Of course, patients who are under anesthesia, they may get perturbations with the coronary, blood flow. And this coronary blood flow may actually due to a problem with the coronaries themselves, and they get a type 1 myocardial infarct. It may also be due to a mismatch between the oxygen that is delivered and the demand that is placed. So, for example, in ischemic states, where you have maybe anemia, hypertension, or malignant arrhythmias, your systemic oxygen delivery may actually be reduced to a point whereby the myocardium is actually stopped. Type 3 MIs, these are maybe sudden cardiac death. Of course, in a setting of symptomatology related to your ST segment changes or a left bundle branch block. Type 4 MI is due to coronary intervention, the PCI, or the presence of a stent. And type 5 MI happens after coronary artery bypass graft. So in the perioperative period, where we're having non-cardiac surgery ongoing, we tend to have a lot of these type 2 MIs. And basically, these are due to global perturbations in in oxygen delivery. So what's the difference between a type 1 and type 2 MI? Of course, type 2 MI, basically, when you look at the supply of blood to your myocardium, the inner parts may benefit from, diffusion of the materials from the cavity. The outer part strongly depends on the coronaries. Okay, so when you have reduced perfusion, global perfusion, the inner parts of your myocardium may get ischemic. And this is the type 2 MI. Type 2 MIs tend to be subendocardial, while type 1 MIs, the ones that are due to coronary problems, may actually be transmural. And so the subendocardial MIs are associated with ST segment depression, while the coronary events that are due to, occlusion of the coronaries are actually present as a ST segment elevation. So what is the criteria for type 2 MI? Of course, we have a depression of your ST by at least 2 millimeters, which is basically 0.2 millivolts. And they have to either be horizontal or down sloping. The upsloping ones may be normal variants. And this has to be present in at least 2 heartbeats. So basically, this picture basically reminds me of a small boy who was admitted to our operating rooms, having sustained a forearm injury as a result of, working with a shaft cutter while feeding the cows at home. So they lost their circulatory volume and they were receiving massive blood transfusion. And when we placed them on the monitor, we could see that something similar to this, that the ST segment, only 2, was way higher than, was more than, 3 small squares, So basically, that's how you monitor. And as you resuscitate and maybe, achieve balance between demand and supply, you may find that your ST segment goes back to, normal or, 0 or something. What about the microcirculation? Because a lot of times we just focus on blood pressure, heart rate, central venous pressure. But in in resuscitation, you find that your microcirculation tends to lag behind your macrocirculation. So in normal physiology, in the absence of cardiopulmonary problems, the blood that is coming back to your systemic circulation from the pulmonary circulation is supposed to be well oxygenated, saturating above 92, carbon dioxide of around 40, and a normal lactates. And then, of course, it goes and sheds the blood to the tissues that need them, so that by the time it's coming back to your central vein, it's around 75% saturated. However, when you look at your carbon dioxide, it has increased by between 5 and 6 millimeters of mercury. And of course, in the presence or in the absence of any other perturbations, then you'll actually remain normal. So normal microcirculation is characterized, of course, by good arterial saturation of maybe above 94 up to 100. It's also characterized by a central venous saturation of around 75%. It is characterized by a normal PaCO2 of 40 millimeters of mercury and a central venous CO2 of around 45 millimeters of mercury. So here we're looking at systemic oxygen delivery. We are looking at carbon dioxide gap between the vein and the artery, which is supposed to be not more than 6 millimeters of mercury. And also we're looking at normal lactates. But what happens when you have, perturbations like in sepsis, you find that the arterial blood may be very well saturated, but of course there's going to be redistribution of blood. Some tissues are extracting more, some tissues are extracting less, and maybe your central saturation may be 80, which may mean that the blood is flowing rapidly through your tissues. There isn't enough time to extract. It may also be lower than 75, which means that the tissues are really hungry. The oxygen debt is too much, and the blood being the oxygen being extracted is more. So whenever you see a central venous saturation of less than 70 or 75, less than 70, you're worried that there is too much, consumption, and it may encroach on your oxygen reserve. Of course, this is characterized again by bigger veno-arterial carbon dioxide gradient, because here the difference was like 45 minus 40 is around 5, and here the difference is around 50 minus 40, which is 10. So it's characterized by a big veno-arterial oxygen gradient, of course, and a lactate that is higher than normal, because when you have your lactate above 2.2, then that may be indicative of perfusion problems. Of course, the central venous saturation is very important. We've been monitoring it for a long time. A state of oxygen balance is characterized by a central oxygen saturation of 75, like we have alluded to earlier on. And what happens is that, when your oxygen delivery is falling, because oxygen delivery is falling from here to here, your oxygen consumption will remain constant for a long period. But it reaches a point whereby when your oxygen delivery goes further, your oxygen consumption is actually dependent on that oxygen delivery. At this point, oxygen consumption is actually independent of your oxygen delivery. At the point where your oxygen consumption becomes dependent on your oxygen delivery, that is a critical point, and that's when you see a significant reduction in your central venous saturation and a marked increase in your lactate. So at this point in time, I think you're encroaching on your oxygen reserve. Of course, oxygen balance, like we said, you have to sort of reduce your central venous saturation. Of course, hypovolemia, hemorrhage, anemia, heart failure, and hypoxemia. Of course, it may increase when you have high cardiac output states, thyrotoxicosis, when you have aggressive resuscitation leading to, supranormal hemoglobin and supranormal oxygen levels. Of course, you can reduce oxygen consumption by treating the fever, pain, shivering, so you have to paralyze the patient. And if the patients have increased work of breathing, you may want to sedate, intubate, and mechanically ventilate. There's a lot of controversy, but because of time, I may not be able to talk about all this. But yes, central venous saturation training is becoming an important aspect because it was used earlier on by Rivers et al., as a protocol that was used to resuscitate patients. However, when you look at the patients in this protocol, they had a central venous saturation of around 50. That is in the year 2001. But in the year 2008, 2007, other protocols came and they said that the Rivers protocol was not good compared to this. But when you look at the patients who are recruited in these two trials, the ARISE and the PROCESS, these patients had already received some form of resuscitation, and their central venous saturation was in the 70s. So comparing these trials is actually not the right thing because the patients were sicker. They had a central venous saturation of 50 in the early goal-directed therapy, as opposed to the ARISE and PROCESS where the central venous saturation was in the 70s. So it means in these two trials, they had oxygen balance and they maybe did not benefit from, all these interventions. Of course, we talked about the veno-arterial carbon dioxide gap. What has been shown is that if your veno-arterial carbon dioxide gap is more than 6 millimeters of mercury, then this was associated with lower cardiac output. And patients who were hydrated with restoration of your intravascular volume tend to reduce their veno-arterial carbon dioxide gradient to less than 6 millimeters of mercury. So it may be something to consider, given that a lot of our patients are already having an arterial line and a central line. So if you do the two gases concurrently and you just take the central venous carbon dioxide and you subtract your arterial carbon dioxide from it, if the gap is more than 6 millimeters of mercury, you may be dealing with a hypoperfusion state. Of course, lactate is a key metabolite traditionally associated with perfusion and hypoxia. We have both non-hypoperfusion and the hypoperfusion context where you can have lactate that is increased. So basically in the situation where there's no perfusion issues or hypoxia, you find that this is actually aerobic system. There's the activity of your beta-2 agonists increasing your glycogenolysis and lipolysis. So you have a lot of glucose-6-phosphate checking into your glycolysis and producing pyruvate. The pyruvate is supposed to go into your TCA cycle, but this cycle may be overwhelmed. And so this product may be shunted to lactate production, which is actually aerobic, as opposed to now the lactate that is due to, hypoperfusion and hypoxic states. So a lot of lactates produced daily in the body, the liver and the kidney are very important in lactate elimination. And we have to sort of monitor the progress of lactates. If there are changes in lactates, between 2 time points, and you're looking at maybe up to 20% hourly reduction, and you want it to happen in the first 6 hours. Of course, there's a pathologic reflex among fluid enthusiasts. Whenever they see lactate, they give a bolus. So it's called the lacto-bolo reflex, because you know very well now there's different types of hyperlactatemia. There's one that is, of course, due to shock states, anemia, hypoperfusion, but there's also the other type of lactate that is non-hypoperfusion or is non-hypoxic. When you have things like gut ischemia, a patient who presents with the mesenteric thrombosis may actually be normovolemic and they may have hyperlactatemia. Renal vein thrombosis, hematologic malignancies, the drugs like, biguanides, beta agonists like adrenaline, liver failure, especially post-resuscitation, the shock liver, and of course, patients who have congenital problems. So the presence of lactate should be the point at which you start thinking, what the cause of lactate is. Of course, it doesn't matter where the lactate comes from, because hyperlactatemia is always a very bad prognostic index. So I think finally I have come to the end of this presentation. Sorry for the small hitches that I was experiencing with my volume. I hope I was clear, and I hope I've managed to just remind the fraternity that we can use the things that are readily available to us and make very important decisions in managing patients who present with features of hypoperfusion. And yes, this has been, I think, physiologic. Thank you, Dr. Ruth.
Thank you very much for the wonderful presentation. Now it's time for question and answers. Does anyone have a question? So, Dr. Idris,
Yes.
Dr. Umani is asking, how accurate is flow track monitoring?
What is flow track? Maybe Wendy can tell us. What are you looking at in flow track?
Hello, Dr. Umani, are you there?
It's similar to the PICO thing which you use that gives you your cardiac output, your SVO2. So they call it like flow track. So I was asking, like, how accurate is it?
So when you look at the dynamic variables, like the pulse pressure variation, of course, on the receiver operating characteristic curve, in terms of trying to predict fluid responders versus non-responders, they tend to perform better than the static indices. So I don't know if it's a question of accuracy or the capability to delineate between the ones who will benefit from certain interventions to the ones who may not benefit. But yes, it's been shown that it may have better utility in predicting changes in cardiac output, cardiac index, upon maybe augmenting your venous return with fluid boluses. And of course, the central venous saturation, like I said, it may be one of the first few things that change before you see changes in your blood pressure or heart rate. The first thing that may change is actually the central venous saturation. So I'm not sure of the term accuracy, but yes, they may be able to pick changes at the cellular level earlier as opposed to maybe the standard approach.
Thank you very much. We also have a question from herself from Rwanda. He's asking, what is the role of capnography in hemodynamic monitoring?
Yeah, that's a fantastic question because, capnograph is basically a measure of your carbon dioxide. And you're hoping that, one, carbon dioxide is, can I say, capacity and flow limited rather than diffusion limited. What happens is that in the absence of reduced pulmonary blood flow, you don't pick any carbon dioxide. So in an arrest, there's no carbon dioxide. But you have seen during cardiopulmonary resuscitation, if you have high quality resuscitation and you improve your pulmonary blood flow, then you'll have very good end-tidal carbon dioxide. So basically, it's a mirror of your pulmonary circulation. Of course, your pulmonary circulation may also be dependent on the systemic circulation. So it may have a role. But also, you have seen that when you're dealing with the mechanical ventilation, the process of mechanical ventilation may also, confer VQ mismatches, and you may worsen your dead space. So of course, capnography is very, very important because the difference between your arterial carbon dioxide tension and your end-tidal carbon dioxide tension may be used to estimate the dead space using the Bohr's equation. So it is very, very important.
Thank you so much for that. We have a question from Hassan Maina, who is asking, why is the arterial oxygen saturation same in arteries and veins for septic states in one of the diagrams that you posted? So
when ideally your central venous saturation is supposed to be around 75%, but when it starts rising to around 80, it means the mitochondria is failing. It's not using the oxygen to carry out the oxidative phosphorylation. So basically, when your central venous saturation is really high, it means blood is just going and coming back without shedding the oxygen. So that may be a sign, a bad sign. It's actually worse than, having a central venous saturation of 60, because you can't do nothing to the mitochondria. This is like the final common pathway to dying, because your mitochondria has failed at that point in time.
Thank you so much. We have a question from Dr. Odaba.
Mm-hmm.
His question is, how accurate is pulse pressure variation in these days of protective lung ventilation, given that the pulse pressure variation was developed using a tidal volume of 8 to 10 mils per kg?
Yeah, so I know we are supposed to use the lung protective mechanical ventilation, where we use the tidal volume of 6 mls per kilo, but you can also do something called the tidal volume challenge. So you transiently increase the tidal volume. In as much as this is an ARDS patient, you increase the tidal volume to 80 cc's per kilo for 1 to 3 minutes, and then you look at the change in pulse pressure. If the change in pulse pressure is more than 2.5%, that patient is volume responsive. Thank you.
Okay, thank you so much. We also have a question from Professor Lema, who's asking, he says that previously we used to rely on the color of blood during surgery, but with continuous monitoring, we don't do that these days. What's your comment on this?
So color is something that is very difficult to deal with. Of course, there are gender issues. Male anesthetists may see color better than female anesthetists. And there are also 50 shades of various colors. So color is a very subjective thing. But digits like saturation of 90, 95, or 98, it doesn't matter who's looking at it, because 99 is 99, whether it's you or me who's looking at it. So when you use digits, you remove the subjectivity. When of course, dark blood is dark blood. But in between now, it may be also very difficult to say what shade of blood color this is.
Thank you. Dr. Diriba has a question, though it's not so clear, but the question is, what do we do if there's no decrease in lactate level after giving fluids? I think he's asking, you said there should be a 20% decrease per hour. I think he says, what do we do when that does not happen?
So you look for the causes. It may not necessarily be a volume issue. It may be things like mesenteric renal vessel thrombosis. It may be, liver failure. It may be enzymopathies, especially if you're looking at pediatric age groups. So you look for another cause. The one that you are trying to address is probably not it.
Thank you. Marcel has another question. The question is, in this COVID era, we mechanically ventilate patients with very high PEEPs, which decrease the blood pressure. So how do we manage this low BP from this high PEEP?
So basically, the different types of patients, they're the patients that have relatively maintained sort of mechanical indices of the lungs. So they have normal compliance. And if you use high PEEPs, that PEEP can actually be transmitted. A big fraction of the PEEP can be transmitted to the heart and the great vessels. So that is in normal lung, relatively normal lung. But in the lungs that are hard as a stone, when you put a PEEP of 20, that PEEP is dissipated by the hard lung, and a smaller proportion of that pressure actually goes into your into your big vessels on the heart. So, number one, you have to realize that the patients are very heterogeneous. So if you find that the patient is getting a low BP as a result of PEEP, you have to sort of choose what you use, maybe do what you call the PEEP titration, and you have to be you have to have a low threshold for starting your norepinephrine, and you also may want to maybe optimize. So sometimes this, like a recruitment maneuver, a formal recruitment maneuver, may actually need some preload to be given to this patient. I know you're supposed to be fluid restrictive, but when you see such a patient, you may want to give a bit of fluid, but also look, are you giving the right PEEP to the right kind of patient? Because a patient with good compliance, above 50 or above 40 cc's per centimeter of water, may actually transmit that pressure to the blood vessels. If the lung is stiff and the compliance is like 15, that patient may actually get a higher PEEP without necessarily getting hypertensive. So you have to look again at your patients. Don't treat all patients the same.
Thank you so much, Dr. Terry. I see that we don't have any more questions. I'll quickly move on to our sponsors. We thank you so much for sponsoring this webinar. I want to invite the company representative, Rogers Nyangeri, who is a trained intensive care nurse. He's a patient monitor and life support clinical application specialist at Minro International. You're welcome. We will be with you for the next 10 minutes.
Okay, thank you so much, Dr. Ruth, for that kind of introduction. And thank you again, Dr. Idris, for that insightful presentation and the clinical information that you've given unto us. I want to appreciate you in a very special way. So my name is Rogers, as Ruth has introduced me. I'm a clinical application specialist working with a Minro International company. I'm in charge of critical care machines and anesthesia machine training. And today I want to introduce to you Minro, our flagship patient monitoring parameters and solution that we have with our company. So without much ado, kindly allow me to mute my, to stop my video so that my audio will be clear from my end, and I'll continue with my presentation. We face daily challenges as we manage our patients in critical care units, and some of the challenges that we face, I've highlighted them here: ease of use of patient monitors. I won't read everything. Alarm fatigue, complicated workflow with our patient monitors, and even the institutional workflows, and even the accuracy and the reliability of monitors and patient monitor that we have. So the question is, how will Minro Benevision series patient monitor offer solution to these daily challenges that we face as doctors and nurses in these critical units and theater? So into the agenda of today, I want to do just a brief introduction of our Minro patient monitors portfolio. And then secondly, I'll talk about the hemodynamic patient monitoring parameters that we have as a company. And then I'll last I'll talk about the hemodynamic clinical assistive application tools that we have that will help doctors and even nurses make a clear decision and even escalate care of their patients. So into our patient monitor portfolio, basically we have three segments. We have the premier segment patient monitors, which we call them the Benevision series patient monitor, which is a full modular design. And with this Benevision series, we are able to monitor all the patient parameters, more than 20 parameters. And then secondly, we have the value segment, which is divided into two, EPM series and UMEC series. So I want to talk about them today. And again, we have the vital signs monitors, our third segment of patient monitors. These are just vital signs for spot checks and monitoring of patients in general wards and even emergency departments. So Benevision N22 is a full modular design patient monitor, and with it, you're able to give you full range of parameter modules that will suit all the clinical needs that probably a doctor or the anesthetist will require in management of these patients in theater and even in ICUs. So, and also the company, we have abundant measurement parameters. And in line with Dr. Idris' discussion today about the hemodynamic parameters, I'll only talk about the most advanced parameters that I've cycled in a red color, the most advanced hemodynamics and the leading cardiac monitoring parameters we have. And with our Benevision series, we are able to provide over 20 kinds of plug-in measurement modules for premium multi-parameter patient monitors. And with this, we are able to represent the most comprehensive solutions that we have in the market so far. So we start with our ECG. Of course, as Dr. has said, is that it is very important for us to monitor our patient ECG when doing surgeries or even in critical care units. And the reason being is that most of the morbidity cases that we find worldwide or globally is that they are related to cardiovascular diseases. And with our ECG, Mindray ECG, is that in terms of accuracy, we have covered in that we use 2 ways to make sure that our ECG is correct and accurate and very reliable. So we use Mindray multi-lead ECG analysis and cross-fusion algorithm technology for monitoring accuracy of our ECGs. And then in terms of a 12-lead resting ECG that we have in our patient monitors, we use the Glasgow algorithm, of which we know about the Glasgow algorithm as the top 3 algorithm in the whole world, which uses multi-variables to determine the accuracy of the ECG report generated. And some of these variables are like gender, age, medical history, race, and so many as clearly shown here. So why multi-lead is that as per the guidance of American Heart Association is that monitors should be capable of simultaneously displaying and analyzing 2 and preferably 3 or more leads. That's why we are monitoring, and we're monitoring our ECG using the 4-lead ECG algorithm. So moving to multi-lead ECG analysis, why is it? Is that having a look at more than 2 leads gives you an accuracy in terms of monitoring your patient. And with this, it can reduce false alarm effectively. Like we can see in this first image here, is that this is just a single lead monitoring algorithm. And the heart rate is at 150 beats per minute, which is clearly an arrhythmia. But in the second image here, we are seeing that we are monitoring using multi-lead synchronized ECG monitoring. And with this, the heart rate is reduced back to 60. So which is a very good thing for us, and it reduces those false alarm. The second technology is cross-fusion. And with cross-fusion, just to highlight is that excessive alarm in critical units and even in operating rooms is a nuisance. And with cross-fusion, it can help to reduce false alarm and thus prevent alarm fatigue. So our question is, how does this cross-fusion work? Is that it uses, is a technology that looks at two signals. With that fusion, it's able to choose which lead is reliable, and with that is able to give you the heart rate. I won't go into that so much because of time. And looking into the ECG configurations we have, is that we're able to do 3-lead ECG, 5-lead ECG, 6-lead, and 12-lead ECG to monitor ST segment analysis and even QT and QTC analysis. With Mindray ECG, you're able to get the heart rate of the patient. Number 2, you're able to detect patient pacemaker and know if your patient is paced or not automatically. Number 3, with our ECG, you're able to identify and even do analysis of ST segment. Also, number 4, with our ECG, we're able to do QT and QTC analysis, And lastly, we are able to do a 24-hour ECG analysis, which is a very unique feature with our Premier Element patient monitors. And with this, we are able to monitor our patient's heart rate within 24 hours. We are able to monitor our patient's ST segment analysis for 24 hours, arrhythmias, and even QT, which is very, very important. When it comes to blood pressure, Dr. Riordan told us about the invasive blood pressure monitoring, how important it is for our patients. And with our patient monitor, we're able to do IBP, and using either of these modules that are highlighted here, we're able to do IBP, ICP, CVP with only that one module, which gives you a freedom of and even reducing cost for an institution in terms of acquiring so many modules to monitor different parameters. So with us, we have only one module that is able to do IBP, CVP, and even ICP. And also we have an inbuilt PPV measurement feature in our patient monitors. And there's a specifically window that is dedicated for pulse pressure variation. And with the numeric wordings or data for that patient that you're monitoring. So coming into our cardiac output, we have three main ways in which we can monitor our patient's cardiac output. Number one is through the gold standard, the normal one, which is through thermodilation principle using the Swangan catheter. Number two, which is less invasive, we can use the PICO module. And the last one is non-invasive, which is a very good one, called the ICG module, which is non-continuous. And we use these modules highlighted here to monitor your patient's cardiac output. So depending, there are factors that you need to consider first before you choose which method that you want to use in monitoring your cardiac output. And it has well been explained by Dr. So, and again, for those complicated procedures like PICO, continuous cardiac output, we have an online guide that will guide even the caregivers who want to do these procedures with the patients so that they are able to do it accurately and correctly. So with this online guide is that it enhances workflow of the caregivers, reduces time for the training, in that you just go directly to the patient monitor, find where that online guide is, you type in the procedure that you want to see how it is connected, and you're able to see that. And lastly, it ensures that there is learning method for junior staffs and even caregivers. So again, we offer solutions to respiratory and metabolic parameters. And as we all know that we use the most advanced technology, the ATIMA, we're able to do ETCO2 monitoring, either mainstream, side stream, and even microstream. And also with our anesthesia units, we are able to do ATIMA, AG module monitoring. And again, with metabolic parameters and gases exchange, we can combine these modules, either of them, to do the gases exchange and metabolism parameters, either ATIMA module with CO2 and O2 module plus the respiratory mechanic module to do the metabolism parameters. And then for volumetric CO2 and dead space, we're able to do all this using the mainstream CO2 and respiratory mechanic module. So lastly, is about the clinical assistive application that we have. And our question is, what are these clinical assistive application tools? So, and why do we need to have this in our patient monitors, and even why do we need to have it so that we can monitor our patient effectively? Number one is that it reduces data overload. There are so many data that we find in our patient monitors. With that data, it gives you an overload that you cannot even make right decision for your patients. With this, it converts complex data into graphical representation, which is more intuitive. Number two, it improves your workflow. And lastly, it helps the junior clinicians to make a clear direction and even escalate care for their patients. So we'll start with Haemocyte. So what is Haemocyte? Haemocyte, this is a very intuitive interface tool that it can integrate all the hemodynamic information that you're monitoring for your patient to help the clinician or the caregivers to have a clear and overall picture on what is happening to your patient. So as you can see here, we have the physiological graphics. It's just an animation which shows you the heart, and the dotted line shows you the amount of fluid that probably you're giving to your patient. And we have the lungs here, and it can also give you the numerics and the parameters you're monitoring for your patient in terms of pulmonary circulation. And lastly, the vessels, in terms of contractility and even vasodilation, you're able to get all this here. So as I said earlier, is that we have so many parameters we're monitoring, and with this, it is very hard to make a clear decision in terms of your patient. So what are the key functions of this Haemocyte? So there are four main key functions. Number one is diagnosis, and in diagnosis, we monitor all the parameters, and they're displayed in this tool. We have the physiological graphics that I've told you about that animation interface. And then we have physiological relationship. Number two, the test. Which are these tests that we do? We are able to do like passive leg raising test, which all of you know, rapid fluid loading for you to test if the patient has got fluid responsive or not. And then from there, we need to do tracking by looking at the heart function curve. And Dr. has talked about the Frank-Starling curve. And then lastly, evaluation. So in diagnosis, We look at the cardiac output parameters, contractility, preload, afterload, oxygenation, and organ function. And they are displayed here on this icon here. So in the cardiac output, there are parameters, there are patient parameters, and against it, there are reference values. And in case there's any value that is low, it shows you using the direction indicated here. So all these parameters are monitored here, and you're able to find the normal and the abnormal parameters of the patient. Number two is that in diagnosis, we have the physiological graphics, and the physiologic graphics displays the monitoring parameters using the animations. The animations, which give a visual representation of interaction of the heart and the vascular system. And the physiology relationship, I saw this this slide with the Tari. I was explaining something about the balance between the oxygen delivery and the estimate oxygen consumption. So with the physiological relationship icon here in the hemocyte, you're able to get that, the balance between oxygen delivery and lastly, the decision model that you need to take for your patient. So, and then in the test, we do the two tests, the main two tests. You can choose which one you want according to your preference, either passive leg bracing or rapid fluid loading. And with that, you're able to, it gives you the results here on this red window. And again, from that, you're able to make your decision right in terms of monitoring the patient. And then in terms of follow-up of a patient, we look at the heart function curve. And with this, it highlights the treatment pattern for your patient and the fluid responsive that you've given to your patient. And then lastly, about the evaluation part is that we have two main tools here of reference, the spreader vision tool and the trends. And in the spreader vision tools, in simple terms, is that it enables you to have a comparison I mean, before and after the treatment that you've given to your patient, if it is fluids or you've given any nootropic support to your patient. And then for the trends, it displays all the hemodynamic parameters and the trends that you've given to your patient and monitor your patient. And then the last part is the infusion view. And in the infusion view, this is just a software that is put in our patient monitors. And we use this software using our pumps. So we have the new model called the N-series pumps, which are connected to our patient monitors directly using a Wi-Fi, or the old model called the SP, the benefusion pumps, where you use this module called the Benelink module to connect to our patient monitors. And when you have that software in our patient monitors, you're able to monitor the fluids that you're giving to your patient together with the vital signs that the patient is having. So with this, it enhances the caregiver's confidence in medication treatment, especially in the administration of vasoactive medications to very critical care patients. So in short, what I'm trying to say is that you have your drug here, the drug that you're giving, probably you're giving propofol or epinephrine or dobutamine, and against it, we have the vital signs up, like the heart rate up in the green waveform. We have the SpO2, and the blood pressure, the invasive blood pressure monitoring. So once you increase probably the dose of norepinephrine, you can see directly what is happening to the vital signs of your patient. So with this, it will give you a very good confidence in terms of monitoring the patient effectively. So with this, it gives you real-time view of the patient vital signs. It enhances the workflow of the patient. And lastly, what does it do? It enhances better clinical judgment and decision-making in terms of monitoring the patient. So that is the end of my presentation. Thank you so much. Hope I've not taken so much time. So if there's any other question, kindly feel free to raise it up. I'll be glad to answer that.
Thank you, Rogers, and Crown Healthcare. I think that was a very informative presentation. Thank you, Dr. Id, for the the presentations can also be found on our YouTube channel on the KSA. CME points will be the CPD points will be sent to your emails. For the clinical officers and the nurse anesthetists, the certificates will be sent to you. Same for the foreign attendees. Also to note is that we still have the conference in August, a virtual conference, 18th to 20th. And this coming week, we have a special CME on ethical challenges in anesthesia, which will be on Wednesday, the 28th from 6 p.m. So take note. And those are the announcements for this evening. Thank you for attending and have a wonderful evening.